Welcome to today's Healthline webinar from the American Association of Kidney Patients, titled Keeping Your Dialysis Access Site Healthy. This webinar is made possible by an educational grant from Medtronic. Thank you for joining us today. My name is Jerome Bailey, and I am AAKP's Director of Patient Engagement and Advocacy. AAKP Healthline webinars fall under our Center for Patient Research and Education. We believe patient and care partner education is an integral part of treatment and protection of patient lives, and we work to ensure that the patient has a central role in research and guidance that are designed to determine optimal approaches and strategies for providing healthcare services, assistance program, and access to new products and services. We built this center with the latest polling and engagement technologies to ensure that kidney patients take a central role in informing the federal, academic, and private sector research shaping the next generation of healthcare services and assistance programs and innovative new treatments. We encourage you to respond to our flash surveys and other engagement opportunities that you receive via email as a reminder as a member of AAKP. As the oldest and largest kidney patient-led organization in the U.S., AAKP is proud to host this webinar as a service to our fellow kidney patients, family members, and care partners, healthcare professionals, researchers, and policymakers. AAKP is a champion for full patient care choice, the protection of patient-doctor relationship, and the elimination of barriers for patient access to available treatment options. Today, we are featuring a very important topic that is vital to patient health, and that is the dialysis access site. The access site is commonly referred to as the lifeline for patients undergoing dialysis treatment. It's important to maintain a healthy dialysis access site as it plays a critical role in both your treatment and overall well-being. To bring some perspective to this topic, we have three great speakers. We are going to begin with Dr. Charmaine Lok. Dr. Lok is a professor of medicine at the Faculty of Medicine, University of Toronto, and senior scientist at the Toronto General Hospital Research Institute. Dr. Lok is also the medical director of both the chronic kidney diseases and hemodialysis vascular access programs at the Toronto General Hospital. Her research focuses on chronic kidney disease and end-stage kidney disease outcomes. She has a special interest in improving hemodialysis vascular access outcomes, improving neuromuscular function and mobility in CKD, and reducing cardiovascular events and mortality in CKD ESRD. She is also active in raising awareness of CKD and ESRD and its importance in population health. Dr. Lok, I will turn the presentation over to you.
Thank you so much, Jerome and the AAKP, for allowing me to do this presentation on dialysis access. So I consider myself a real patient advocate, and there is nothing that gives me more satisfaction than to be able to give information to patients to self-advocate about keeping your dialysis access site healthy. Today we're going to discuss the strategies for a healthy dialysis access and how it's important to know your plan, your PLAN. And that's a new foundational concept for vascular access. You may not know about it because it's quite new, and that's what we'll talk about in this presentation. I'm going to talk about the significance of your overall health on keeping a dialysis access healthy, and talking about the aspects of the plan, which includes the creation plan, which involves the choice and types of dialysis access, preventing complications and knowing what to do about them when they occur, and what to do with regards to planning the next access. So first, I'm going to talk about how the landscape is changing. In the past, we've had KDOQI vascular access guidelines supported by the National Kidney Foundation, and this was a roadmap for caring for dialysis access. The last update was in 2006, and the most recent update came up in 2019, during the pandemic. So a lot of people are not aware of the new guidelines and the new concepts. Just to let you know, these guidelines were developed by a multidisciplinary work group There was an independent evidence review team that drew out the data from many manuscripts, and together we reviewed over 4,600 manuscripts to develop these vascular access guidelines. There were over 250 evidence tables, and we developed 26 guidelines and subsections. Very importantly, there are some new concepts and innovative implementation plans for vascular access that I will discuss. So why do we have guidelines? We have guidelines to serve our patients, and you can see here in this picture that these patients are quite different. At the top, we have a middle-aged man who has hypertension, heart disease, peripheral vascular disease. That's chronic kidney disease, not yet on dialysis. At the bottom, around 5 o'clock, we have a young adult who with glomerulonephritis has already been on peritoneal dialysis that's failed and needs to have hemodialysis. Across from this young woman, we have another young adult who is full of life, has congenital cause of her end-stage kidney disease and no comorbidities, and is an ideal candidate for kidney transplant and has living donors. At the bottom in between at 6 o'clock, we have an elderly woman who is functionally very independent, is doing volunteer work, takes her grandchildren to school, and very active. In contrast, the elderly man at the top around 11 o'clock, he's elderly, is receiving palliative dialysis, and just waiting until he has his affairs in order and able to say goodbye to his family members. So as you can see, these patients are very, very different. And when we think about dialysis and dialysis access, should all of these patients go on to hemodialysis, and should they all have the same vascular access? And clearly the answer to that is no. So the guidelines have a new concept, and that new concept is getting the right access in the right patient at the right time for the right reasons. And when we talk about vascular access, there are three types of vascular access. The arteriovenous fistula, which is a connection between the artery and the vein, and the high flows from the artery develops the vein and makes it tough so that two needles can go in to deliver dialysis. A graft includes a synthetic or non-autogenous material between the artery and the vein, and the two needles go into that tube to provide dialysis. And a central venous catheter is a plastic tube that goes into a blood vessel into the heart where blood is brought to the machine and brought back to the patient. So these are our forms of dialysis access, and patients not always need to use just one access, but is able to use the various choices. So one of the key concepts in the new guidelines is not simply fistula first and catheter last. Fistulas are an amazing access, and if feasible, they should be considered, but it is not appropriate for all patients. And catheters are not always the last access for all patients because they are valid in some patients. So what we need to do is think about what is the right access for the patient. And in order to do that, we have to have a plan, a PLAN. So when we think about the ESKD or kidney life plan, we need to think about the stages of chronic kidney disease. We know that there are 5 stages of chronic kidney disease. And when you reach stage 5, it's actually not the end. In fact, it's the beginning. It's the beginning of the life of a patient with end-stage kidney disease or kidney failure. And in order to maintain that patient's life healthy and active and optimal with kidney failure, we need to have kidney replacement therapies. They come in the form of hemodialysis, peritoneal dialysis, and transplant, and all of their subtypes. So for example, a patient may need to start on peritoneal dialysis and with peritoneal dialysis access. And with that, they may have many years of peritoneal dialysis until it fails, and then they would go on to hemodialysis with a vascular access. The patient may then get a transplant, and there would be other implications for vascular access. Another patient's trajectory might start with a transplant, and then they would go on to peritoneal dialysis with a dialysis access, and then that may fail, and then they would need hemodialysis with their types of vascular access. So this chain or pattern of therapies is called the ESKD life plan, and they have an associated dialysis access. So when we talk about the plan, the PLAN, the P stands for patient, L is the life plan, and the access needs is the access life plan. And this is designed to get clinicians and patients to think about the next access and plan for it. So we have the plan. So many patients and clinicians don't know about this plan because, as I said, the KDOQI guidelines came out at the peak of the pandemic, but you can look at the National Kidney Foundation website and it will point to these resources that talk about the ESKD Life Plan that is very interlinked with your dialysis vascular access plan. So let's just focus on the access needs because this seminar is about vascular access. Let's take a look at what is really important with regards to keeping your dialysis access healthy. And so we have a creation plan, a contingency plan, and a succession plan. And underlying all of that, you have a vessel preservation plan. And a thoughtful surgeon once said very eloquently that every access is precious and has to be managed carefully and in consideration of future access. And with this access plan, it takes this into consideration. So let's talk about the access needs or the access plan. So let's next talk about your overall health maintenance and how it affects your dialysis access. And with this, we're going to talk about the access needs and the vessel preservation plans. So who is responsible for your overall health maintenance? Well, of course, you are, as well as your family members and friends that support you, but also the other casts are your nephrologists, your surgeons, nurses, technicians, and interventionists. And what is really important is to know that you have chronic kidney disease and the appropriate time to talk about the ESKD Life Plan and referring for vascular access. And this typically is when your eGFR is 15 to 20 milliliters per minute. After the life plan is created, it needs to be regularly updated by your responsible team members. And this is really important for you to communicate. So what's important to you? Here I have a picture of two patients who are exercising on dialysis, and that is what they have in common. However, their life circumstances and priorities may be different. One may want to see their daughter graduate, one may want to have more time with their grandchild, and one may want to go to a wedding. They also may have different health considerations. They may have plans to maintain health, exercise, and they may have medical events. So for example, a patient could have a stroke or a heart attack or fall and have a fracture. And this is really important to communicate to your vascular access team because it changes your life plan and it may also change the dialysis access. In this situation, for example, a patient is having rehab while on the bottom right-hand corner, this patient has become really ill and her whole trajectory has changes. So it's really important to communicate to your team. But for you as a patient, in terms of overall health, it all comes down to having a healthy dialysis access. And in order to do that, you have to have healthy veins as a foundation. And it is really important to protect your veins. And this is really highlighted by many organizations, such as government organizations. The ANA organization has campaigns for it, international conferences, as well as patient care groups. So saving your veins is really critical for dialysis vascular access. It's not only done internationally, but locally. This is just a picture of my clinic and my two CKD educators with a poster that says, "Save my veins." In addition to having local support for this, there's also international support. So on the website, there is an organization, www.saveyourvein.org. And if you go to this website, there's a lot of resources and information in terms of how you can save your veins and protect them for dialysis vascular access. Now, why are your veins so important? It's so important because you need to have healthy, non-damaged veins to create that AV fistula and even your AV graft. What we provide in the clinic is to have a bracelet that says, use the back of my hand veins to get blood work, because that is where it's safe and doesn't cause damage. If you use vessels in your forearm or in the elbow area, that directly damages veins. That is very necessary to create an arteriovenous access. So how can we protect our veins? If you have chronic kidney disease, if you're on a PD, if you have kidney transplant, you may one day need to go on to hemodialysis and you need to save your veins. So key points are use the back of your hand to get blood work, to get IV infusions. If you need to have blood work done multiple times, and you do need to use any vessels in your arms and forearms, make sure that those sites are rotated. Use a manual blood pressure cuff instead of a mechanical one, because those mechanical ones can cause a lot of force on very fragile veins and damage them. Again, try not to use any veins in the forearm to have blood drawn, to have IV fluids in, or drug infusions. Believe it or not, it's really important to try to avoid a central venous catheter in your neck, or what is called a PICC line in the upper arm, because these lines actually cause damage to the inside of the vessels that can cause narrowing. And if there's narrowing, then if a fistula is created, there is very poor flow back into the heart, and it really prohibits the AV fistula from being created properly and developing properly. If that happens, then you certainly need to get your nephrology physician to advocate for you if you need a PICC line or a catheter, and to give advice in terms of other alternative options. So here's an example of an 80-year-old man who already had an AV fistula and how he protected his dialysis access. So on his arm, you can see that there's a piece of tape that says no IV, no blood work, and no blood pressure cuff on this hand, because he is protecting his very important lifeline. So how can we save our veins after we have our access? So don't forget, a fistula is a big vein. So when a patient is on dialysis, we really, really need to protect it and keep it healthy. So one of the things that we can do to avoid what's happened here in this picture, which is a major infiltration injury, is to have our providers help us. So that's created the AV fistula. Create a diagram to show the nurses and technicians how deep is that fistula, where should you put the needles, and if there's any question, to use an ultrasound before what we call cannulation, or putting the needles in. If the person that is doing the cannulating, the needling, is the nurse technician, or even yourself as a patient, we need to remember that the first time a fistula is used, that the best cannulator possible should be the one to put the first needles in. We always want to use proper techniques, so no bad techniques such as one-side-itis, where you're always kind of putting the needles around the same spot, because that weakens the AV fistula and causes those ugly bulges that you see. We need to make sure that we're always using the right size needles and the right blood flow rates in the dialysis machine, so that the new fistulas don't get damaged. If your nurse or technician, or if you are the one that's cannulating, are having problems, don't keep on trying to poke and poke, but get some help. If there is an infiltration injury, and they can happen very commonly, even with really expert cannulators, you need to treat them immediately. Put ice on, make sure that the swelling comes down immediately. One of the things that also causes problems is that if the healthcare providers get too used to using catheters are really easy to connect and disconnect, and they're painless to patients. But what happens, a side effect, is that they lose their skill in being able to cannulate that fistula. So always make sure that you keep on the skill if you're the one that's cannulating yourself, and that the dialysis units have education programs to make sure that the competency of the cannulators are maintained. So you are the best person to advocate for healthy veins, which is advocating for healthy AV access, which is really advocating for your AV lifeline. So nothing about you without you, especially when it comes to your vascular access. This is important for you as a CKD patient before you start on dialysis, as well as a hemodialysis patient, because you may need another vascular access, as well as a peritoneal dialysis patient, because your PD technique may fail at some point, and even a kidney transplant patient, because while kidneys transplants are ideal, they may not last forever, and at some point with your ESKD, you may need hemodialysis. So let's talk about the next part of the access plan, which is the creation plan. And the creation plan involves choosing the right access. And this is a picture from the KDOQI guidelines. I'm not going to go through all of this, but you can see that there are 4 different scenarios that are very different. The 26-year-old woman has a radiocephalic fistula. The man following her has an early cannulation graft. This elderly woman has an upper arm fistula, and the man at the bottom has a central venous catheter. I'll just say a few words about him. He's a patient on palliative care, very frail, but he still enjoys what time he has left with his family. And this is a very valid reason for central venous catheters. I'm not going to talk too much about catheter care in this seminar, but there are valid reasons for central venous catheter use. So with regards to the access creation plan, the components are who, what, where, and when. So who is going to create it? What type of access are you going to get? When will it happen? The planning is very important. How will it be done? Is it through open surgery or by endovascular technique? The planning is really critical in order to maintain a healthy access, because you need to have the right access to begin with. And in order to determine that, there's many different evaluation techniques, but vessel mapping is really important in patients who need it. Not everybody needs it, but many people do. So who needs to have their vessels mapped? So patients who are at high risk of their fistula failing, so elderly patients, women, patients with peripheral vascular disease or prior damage to their vessels, patients who have had catheters, and as I said before, that's an increased risk of that vessel narrowing and problems with your fistula developing. Patients with prior surgeries or PICC lines in the upper arm, or trauma to the neck, chest, or upper extremity. Sometimes in patients who have a bigger body habitus, it's important to get vessel mapping so that the surgeon can see what the optimal vessels are and whether or not they need to be elevated, so that when it's time to use it, that the nurses know how deep it is and that it's easier to access. So what can you do before surgery to help keep that vein healthy and to optimize it for an AV access? So beforehand, again, you can protect it in all the ways that we talked about, and you can prime your veins. You can do arm exercises beforehand, and again, avoid catheter if you can. So here's a picture of a patient who did arm exercise before they actually had surgery, and you can see how beautiful this vein is, nice and plump and ready for the surgeon to be able to create that access. So you want to be able to provide the best material you can to your surgeon to create this AV access. What about after the surgery? It is really important to look after your AV access after your surgery, and in doing so, you need to follow the instructions given to you post-operatively. If you see anything abnormal, any drainage, pus, warmth, or redness over the incision site, call your provider. If your arm becomes more swollen than immediately after surgery, again, call your provider. One of the things that we want to do in terms of protecting your AV access arm is do not wear restrictive clothing or jewelry that is going to cut off that AV access. Don't sleep on the same side of that access. Don't carry bags or the handle of the bags over the forearm, or use blood pressure cuffs. Don't get blood work in that arm, and don't pick or scratch the scar of that incision. What you want to do, and we'll go into detail about this in a few slides, is you want to make sure that you feel the flow of the AV access, and we call that a thrill. You want to protect and prime your veins, as we talked about before, and you can start priming your veins after surgery. About 2 weeks after surgery, you can take a ball and start squeezing it to help that fistula mature. And again, once again, we want to try to avoid that catheter if you can. So next, we're going to talk about the contingency plan, or what to do when you have complications. So this complication plan is really important because ultimately complications may happen. And the most important thing to do is to monitor and prevent these complications, and if they occur, know what to do. So for a fistula graft, it's very important to keep it clean. So you want to wash it with soap and water. When you're using it for dialysis, again, to rotate the needle, placement site, and avoid this one-site itis. You want to protect your access from external pressure or damage, as we already talked about, and you really want to look for things that are abnormal. So after dialysis, if your access site is bleeding longer than normal, that is an important predictor or indicator that there is a narrowing in the vessels, and that needs to be brought to the attention of the provider. For central venous catheters, you want to keep it clean and dry. So we want to avoid swimming, ideally no showering, but if you have to shower, do it with caution. You can get shower caps that cover the central venous catheter. You want to do dressing changes at an appropriate interval, at least once per week. and more if you need to, but you don't have to have it changed at every dialysis. The more you manipulate it, even if it's cleaning, you're putting it at infection. So just appropriate dressing changes. And you want to keep it away from sharp objects. So if, for example, you're a home hemodialysis patient, I actually had a patient who was a home hemodialysis patient, and they were trying to cut their hair and accidentally cut their catheter. So stay away from scissors and other sharp objects. Monitoring your access is really critically important to keeping that access safe. And we already talked about after surgery that you're going to see your provider 2 to 4 weeks after the AV access is placed to make sure that it's healing well and it's maturing well. Following that, and once you start on dialysis, you need to look at it every time before dialysis. And what we're going to do is you're going to check the access in a look, listen, and feel manner. So while your provider, the nurses and technicians can do that, it's something that you too can do to protect your access. So let's start with looking. So what you're going to do is take a look at your access site, be it your AV access or your central venous catheter. And the most important thing is to know what it normally looks like. If there's any change, if there's any redness, swelling, drainage, and if that access starts to develop what's a bulge or what we call an aneurysm, and it starts getting bigger, then you need to call the provider. If the skin looks shiny or if there's bleeding or peeling skin, again, contact your provider. So I'm going to show you some pictures so that you know what to look for. It says that they may be disturbing, but they really aren't. So here you can see a patient, and it may be a bit subtle, but I can see it quite clearly that the access arm is more swollen than the non-access arm. So this is an abnormality, and this is something that you should tell your provider. This typically indicates that there is a narrowing to the outflow. So you want to look for changes in the skin color, swelling, bleeding, discharge, or any change in appearance. You can see here that this patient's hand looks a little bit swollen, and this patient went to the provider and they suspected a narrowing in the blood vessels. So what they did to treat it was they brought them to have what's called an angioplasty, where they used a balloon to open up the narrowing. And afterwards, you can see that the hand has reduced in size, so the swelling has gone down. In this picture, you can see at the tip of this patient's ring finger is that there's a little ulceration, and that is a sign that the circulation isn't going to the hand. So the high flows from the fistula is stealing it away from the circulation to the hand, and that's what we call steal syndrome. And when you see these ulcerations, it is something that you should definitely tell your providers, and it's often very painful. On the left-hand side, you can see that this patient's hand is very mottled, and there's an ulceration on the finger because this patient has Steele syndrome. On the right-hand side, you can see that the access looks really purulent and friable, and this is a buttonhole infection. Buttonhole infections can occur in patients who self-cannulate or patients who are cannulated by nurses through the buttonhole, and this is something that is extremely serious and needs attention. Here's a test that you can do that helps determine whether or not you're going to have a complication called a stenosis in the AV axis. And a stenosis is just a narrowing. And when you have stenosis, it can often lead to a clot. So this is something that we want to look out for and try to prevent. So this very simple test is called the arm elevation test. And so if you have a fistula and you drop your hand down, you can see in this picture A that the fistula is bulging, and that's normally what happens with the fistula because the blood flow goes down. If you raise your hand, then normally the fistula collapses because the blood flows to the heart and that blood is drained. However, if you have a narrowing and you raise it, then that bulge will not go away and it will remain distended. And so here is just a picture depicting that. You can see that when the arm is raised, there's an area of stenosis or narrowing, and that upper part will remain distended. So that is a sign that there is a narrowing, and that is something that you should inform your provider. To ensure that your AV access is healthy, we're also going to listen to it. You may not be able to listen to your access depending on where it is, but if you can put your access next to your ear, and you'll be able to hear a hum. So what you want to look for is whether or not it sounds the same as before, and if there is no sound. If there is no sound, that means there's no flow through the axis and that there's likely a thrombus or a clot. And this is abnormal, and you should let your provider know. In this next figure, I'm going to share with you what the sound sounds like in a normal access. When you listen to it, you should hear what's called a bruit. So that nice rhythmic whooshing sound is normal. When it's abnormal, it becomes shorter and more high-pitched, and it sounds like this. So that gives you an idea of what a normal fistula and graft sounds like versus an abnormal one. But the most important thing to know is what yours sounds like, and if there's a change, to let your provider know. The next thing we're going to do is we're going to feel. And when you feel the access, that is called a thrill. And so what you want to do is get an idea of what your access feels like. Okay, so now we're going to feel for a thrill. What you're going to do is you're going to put your finger over the AV axis, and what you should feel is an axis that is soft and compressible. You can see that there's a nice small undulation, and it just feels like a buzz. You can see in figure B that there's a narrowing, and if you put your finger, that narrowing will cause a backflow, and that nice, soft, gentle pulse will become bigger and bounding, and that is not normal. What you can do is you can also use your palm, and that gives you a better feel, so that when you have your hand on that axis, it should feel stronger at the incision site and gently dissipate as you go towards your head. If that pulse or that bruit or that buzz goes away, then that's not normal. That means that you're not having appropriate blood flow or no blood flow to that axis, and you need to contact your provider. I'm going to talk about emergencies, because there are emergencies, even though rare, that can occur, and you need to be able to have some life-saving measures, because not only is your access your lifeline, but it can affect your life. So these are things to look at. If you look at your access and you can see that the access has thinning skin, if it becomes shiny, if the bulge or the aneurysm starts to get bigger, if there's infection, increased redness, all of those things need attention. One of the most critical things that you can notice is this thing that looks like a scar. And what that is an access that is about to rupture but is being held in place just by some clot over that access. Here is a picture of an access that I saw in the emergency room, and you can see this thing that's looking like a scar that's going to develop similar to that other picture, and this is a picture of an access right before it actually ruptured. So when you see something like this, you need to contact your kidney doctor or your surgeon right away. So here is an access that is about to rupture, and it is pretty darn scary looking. So if you see something like this, this needs help immediately. It is also very important that during dialysis that you don't have it covered under blankets. I know it's sometimes very cold in dialysis, but the nurses need to see the access in case there's a needle dislodgement or if a fistula might actually rupture. Ruptures don't only occur in the dialysis unit, they can actually occur at home. And I know that sounds really scary, so it's very important to be prepared. So you should have some gauze packets, maybe 4 to 8 packets, and put it where you normally would be, in your house, in your car, at work, or at school, and have a roll of adhesive tape. If the fistula should rupture, just call for help from anyone. Call 911. If you can, get the gauze out and apply pressure with at least 2 fingers and keep a hold on that access. If your access is in the forearm, you can raise your arm with your pressure held tight. And if you can't hold pressure and keep your arm up, just hold that pressure and do not let it go until help arrives. This is really life-saving. Lastly, I'm going to talk about the succession plan. So if your fistula looks like it's about to fail, and signs that it's going to fail is if you need to have interventions multiple times in a year, it's time to think about a new AV access. And the best thing to do is to strategize it beforehand. Here I have a picture of my dialysis patient playing chess, and he's strategizing, but it's really important to strategize about the next access. And that's what the whole ESKD life plan and access plan is all about. So it's really important to have that PLAN so you know beforehand that when that access is starting to fail, the next access that will go into place, what it will be, how it will go in, who will put it in, and when it will go in. And with that, I want to just share a few last pictures. This is a patient of mine who had the right access at the right time, and it was personalized for him. He had a fistula that was 37 years old, which only required one intervention. And you can see that access, it's beautiful. And you can see the little cannulation marks. He had rope ladder cannulation. And when he had this fistula created, he was less than 30 years old. He had kidney limited disease and no other comorbidities. So this really was the right access for him. On the other hand, we have this patient who is an elderly patient, and he felt that a catheter was the right access. He was given the risks and the benefits, and he actually had a catheter for 17 years without a problem. And this other patient of mine had a graft, and she had very few problems with this graft. So every patient has their own medical and life circumstances, and their AV access should go accordingly with it. So I just want to end off by giving you some resources. This is a QR code to the guidelines that has tips on how to keep your dialysis access healthy. And with that, I really want to thank Jerome and the AAKP again for inviting me to do this webinar, and we now have time for questions. Thank you very much.
Dr. Lok, thank you for that thorough presentation on dialysis access care. We have a few questions that people submitted when they registered for the webinar that I'm hoping that you'll be able to address. So, is lifting weights dangerous for your dialysis access?
So if you have a properly created access, lifting weights is actually beneficial. As I showed you, after your access is created, squeezing the ball and gentle weights is appropriate. It depends on how much weight you lift. You don't want to be lifting, 10 or 20 pounds, but anywhere between 2 and 5 pounds may be very appropriate and safe.
Thank you for that. Another question we have is the person says, I have a graft. What should I do if the access site is still bleeding somewhat after removing the bandage one day after dialysis? What if the access site is swollen and or bruised?
Okay, so it sounds like there's a few questions together. They may or may not come together. If an access is bleeding a day after dialysis, then that means that there's a problem. So to me, it means that there's probably a narrowing that's causing the blood to continue to come out. It depends also if the patient is on a blood thinner or an antiplatelet agent. Regardless, it should not continue to bleed. So what I would do is go to the provider and let them know about it. And this patient probably needs to have some imaging to see whether or not there is a narrowing. And if there is a narrowing, it can be opened up with a balloon angioplasty. If that bleeding is also accompanied by swelling, then that again is an indicator that there is a narrowing. Now, the question about the bruising and the swelling, I'm not sure if that's at the same time, but it is common to have what we call infiltration injury at the time of needle cannulation that can cause some bruising and swelling, and really you need to treat that with ice to make sure that it doesn't get worse.
Thank you, Dr. Lok, for sharing your expertise on how patients can effectively care for their dialysis access site with the aim of preventing infections and minimizing the risk of unnecessary trauma or injury that could lead to complications. Let's now hear from Christine Hernandez. Christine is an AAKP member, ambassador from Illinois, and home hemodialysis patient. She also worked as a registered nurse for more than 10 years before her world was shaken in 2016 when she was diagnosed with kidney disease. Christine recognizes the pressing need to ensure that kidney warriors like herself are granted the rights and legislative support necessary to lead fulfilling lives free from unnecessary concerns. She joins us today to share her kidney disease journey and why dialysis access care is important to her. Christine, I turn the presentation over to you.
Thank you, Jerome. My name is Christine Hernandez, and I am a registered nurse and a hemodialysis patient, a home hemodialysis patient from Illinois. In 2016, I had got some devastating news telling me that from my doctor informing me that I was diagnosed with a really rare genetic condition called MUC1, MUC, and the number 1 kidney disease. When the doctor informed me that I was diagnosed with the disease, he also informed me that I was only having 2 options for treatment. One was dialysis, and the second one was transplant. So I started doing some research in what modalities would work better for me, which was important. And secondly, I also wanted to find out about different types of fistulas that would work for me, because I was looking for fistula that was less invasive and fistula that works for me. Each person, each kidney patient should have an option. We don't have a lot of options. So looking into that when you're diagnosed with kidney disease is really, really important. And it was important to me. And I did some research on the type of dialysis that I was going to do, which was hemo, and ended up doing home hemo. And then I also was looking into the type of fistulas that I was looking into. So I did research in the type of fistula that worked best for me. I literally Googled into Google least invasive, less risk of infection fistulas. And the fistula that popped up, I took it to my doctor. I read a few of them, and he informed me that they were able to do it. So I have a minimally invasive fistula like I wanted, and I've been doing it for 4 years now. It's worked really great for me. I really haven't had any issues with my fistula. It looks great. It works perfect for what it has to do. And also, a challenge that I had with the fistula was that it was a fairly newer technology back then. And the dialysis centers weren't really experienced in my type of fistula, so they had to get trained and stuff like that. So, like I said, it has to be a fistula that works for you. You have options out there. Taking care of it is vital. So I every time before dialysis, I wash my hands, wash my arm, make sure the fistula site is very clean, and knock on wood, I haven't gotten any infections to date. So self-care is important when you have a fistula, and making sure you wash it. And aftercare is very important too. So after dialysis, I always, after it's healed up, I wash it. I put some Aquaphor on it, make sure it doesn't dry up. And then I also, at night when I sleep, I make sure that I have, I don't bend my arm when I'm sleeping. I'm like very conscious of that. And even when I'm on the phone, I remind myself, hey, you got to keep your arm straight. You don't want to fold it too long because it causes clots. It could also stop the circulation. So there's things that you could do to manage your fistula, decrease your risk of infections, and make sure it stays working, because it got to be function for the rest of your life, right? And I'm hoping this will be my only fistula. This has been my first and only, and I hope it continues to work. And it's been successful for me. And anyone that is considering getting a fistula, you always have to take care of it. You don't want to get infection and end up in the hospital with sepsis. So make sure you take care of your stuff, clean it, keep it clean. Don't ever touch your fistula with dirty hands, or try to kick at the scabs or anything. Some people do that. I know it doesn't sound too appeasing, but it happens. And just making sure that you take care of your fistula. It's yours. You have to love it. Back to you, Jerome.
Thank you, Christine. for sharing your kidney journey and why dialysis access care is important to you. We appreciate you taking the time to be with us today. Our next speaker is Terry Perez. Terry is a teacher of the deaf and hard of hearing in Florida. In 2004, her primary care physician referred her to a nephrologist. Within 4 years, she had been placed on the transplant list and started peritoneal dialysis. In 2009, she received a precious gift of a kidney from a cousin. However, due to various circumstances, the kidney failed and she began hemodialysis in 2014. Since being diagnosed, Terry has become increasingly more proactive about kidney disease by advocating for herself, sharing information with other dialysis patients, and raising kidney disease awareness in her community. She strives to help others become more proactive in their care and help others reduce the probability of advancing or acquiring kidney disease. Terry, I turn the presentation over to you.
Thank you and good afternoon. My nurses laugh because they say that I'm an anomaly in a way because I think I have access all the types of dialysis pretty much that's available. Initially, I started out with a PD catheter years ago, and I was doing manual exchanges 4 times a day. And I did that and chose not to use the cycler because it was going to be short term. So I did that for about 7 months and just made sure I kept my access clean. Always stayed on my schedule. And so then after transplant, I ended up back on dialysis. And I had to go on hemodialysis. So I had a permacath put in my shoulder and had that for a while until I was able to get a fistula placed. So I got a AV fistula, arterial venous fistula in my arm, and was in center dialysis for 5 years, 5 to 6 years. During that time, I went 3 times a week, and I made sure, I always attended my treatments. They basically helped me with the care of my fistula. I always kept it covered and clean. And if I was going out to something, sometimes I would, cover it. So I did that for a while, but it wasn't working for me anymore emotionally. And so I decided I wanted to look into doing some kind of home dialysis. I looked into a PD catheter. It wasn't available. So at the time, so I started looking into home hemodialysis. And so I elected for that. So I started doing the training for that. I feel like I rushed it through maybe a little bit because I was so determined to get off of in-center dialysis. Probably should have done the training a little bit longer in terms of accessing my fistula. So I did that for a few months. I did become septic, and it was mainly the one a part of my access where I was sticking myself because I would access myself with the needles. And that one had been giving me difficulty even from the time I was training. And so I ended up becoming septic and ended up in the hospital. I had been very vigilant, about keeping my machine clean, keeping my arm clean, the whole bit, cleaning it before I started my treatments. But because that one was giving me issues and having to reinsert the needle, then it became infected. So I lost my fistula, it ruptured, that can happen. And So I ended up getting a permacath again in the hospital, and then elected for the PD catheter. So that's what I'm doing currently. I have a cycler at home. I have a catheter in my right abdomen. And I love the cycler, doing it at night. I use Alkavis I use a cleaner to clean my catheter. And prior to disconnecting, I even will clean it sometimes when I come out of the shower. There's a new issue with a waterborne bacteria, and so I make sure that I keep my shower head clean. I actually turn away from my shower head when I shower, so water's not directly hitting my catheter and my exit site. I use an antibiotic cream around my exit site to help minimize infection in that area, and it's checked regularly by the nurses. So just making sure I keep my machine clean, keeping my exit site clean, keeping the catheter clean, closing the doors, no circulation while I'm connecting and disconnecting from the machine, and also setting up my machine. And then I run 9 hours a night on the machine and just wrap it up in the morning. And it's important to cover your exit site always. Make sure it's well covered, and to make sure that your catheter is taped down so that, it's not catching on anything during the day when you're out, especially if you go out to work or have other errands to run. So that's been my journey with dialysis. Basically, I've experienced pretty much everything that's out there. I did once look into the invasive when I had to go on dialysis again, but it wasn't available here. And so I didn't really have that option and didn't pursue it very much.
Thank you, Terry, for sharing your kidney disease journey. We have a few questions that people submitted when they registered for the webinar that I'm hoping our panelists can address. First, Christine, what type of dialysis access education did you receive prior to starting dialysis?
So my provider went really strict, do not bend your arm, wash it prior to all treatments, make sure after it's clean, never touch your access site with dirty hands. If you have a pet, make sure it's covered when you have an open entrance, right? And gave me a big list about the rules when you have an access, how to take care of it, and how to try to make it last, if possible, for the duration of the time I would be on dialysis in my life. So I took that literal and just literally started okay, I am not going to have my access stop working. So when I went to sleep at night, I made sure it was covered, the entrance, and I would literally put my arm in a pillow sleeve with a pillow so it wouldn't be hard. And that way, if I tried to overnight move it or bend it, because you don't know what you're doing, it would keep me from moving my arm and bending it. Then another reminder I put myself, and you get used to it as you go along, is when you're on the phone, try to answer with your arm that doesn't have the access, because we tend to fold it, and have, it's just natural. So getting used to it is number one, getting acquainted and asking your provider all the questions about access care is crucial to make sure you don't get infections and making sure it lasts the lifetime you need it to last.
The same question for you, Terry. What type of dialysis access education did you receive prior to starting dialysis?
So I'm fortunate that I have practitioners, service providers that share information. So the first time I had my PD, as I stated before, they showed me videos and had me speak to someone who had experience with one type of fistula. They also let me, one type of dialysis access. They also let me visit the dialysis center once I had decided that I wanted to have a PD catheter and talk to the nurse that did the PD training. So I was able to ask questions of her as well. Then when I was interested in doing home hemo, they actually had someone coming around to the center to talk to patients about different types of home dialysis. And so I was familiar with PD, the cycler, not as much. So I was able to get more information about that and talk about home hemo. And since PD wasn't available, I elected for the home hemo. So I had a lot of information. I was able to ask my doctor, my nephrologist, lots of questions. I always take notes and ask lots of questions about everything. So I think that's what's made me more proactive about my own care. And then my home hemodialysis training was 4 weeks. So they were very thorough. They also did a home visit, and I did a treatment at home to make sure it was running properly. When I started peritoneal dialysis with the cycler, I did a 1-week training, and then they also had me do a home visit where I did the cycler at home so they could make sure that I understood what was expected. My nurses do patient education every time we go in for lab day. I'm able to ask my nephrologist any questions that I want, any questions of the nurses. I feel like I have open access to them and can contact them. Even in the evenings, we have an on-call peritoneal number. So if I'm not unsure about something, I can call. I have the support of the company that supports the machine. So if I have an issue, I can call them and ask them questions. I have a booklet, which I have gone through and they went through with me when I did training. And so I feel like I have a lot of support. And I constantly am asking questions and looking into updates. I've participated in some studies related to peritoneal dialysis. So always want to learn more and be able to do more to help patients in the future. So that's what happened for me. And I hope that you all will, if you have to make that decision, will ask lots of questions, investigate, talk to other patients, talk to the providers, and make a decision that's best for you, and don't feel like you can't change your decision.
Thank you, Christine Hernandez and Terry Perez. Your presentations were very informative. If anyone watching has any additional questions for our speakers or about today's webinar that we were unable to get to, please send those questions to info@aakp.org, noting the webinar title in the subject line. I'd like to close today's webinar with a few slides on additional resources that may be of interest to you. If you are not already a member of AAKP, we encourage you to join. AAKP offers free membership to patients and their family members, as well as living kidney donors. To become a free member, join online at aakp.org or by phone at 1-800-749-2787. 2257. To receive all the benefits of membership, please be sure to include your email address when signing up. As an AAKP member, you will be notified by email when opportunities arise where your opinions and experiences are needed to help inform innovative, advanced care and make meaningful, impactful impact to improve lives. We encourage you to respond to our flash surveys and other engagement opportunities to help us elevate the patient voice and change the status quo for kidney disease care. You can also select to receive any of our 5 different electronic newsletters. And I encourage you to subscribe to our printed magazine, AAKP Renal Life. We also invite you to follow us on our blog and social media for all the latest news and announcements. AAKP is dedicated to helping kidney patients across the disease spectrum understand their condition and take control of their health care. We are proud to offer a variety of resources for both patients and care partners. By visiting our website at aakp.org and clicking on the AAKP Store button at the top of the homepage, you can find a variety of educational brochures and online tools to order or download, including our Understanding Your Hemodialysis Access Options brochure and our Conversation Starters, questions to ask your healthcare team about choosing the right therapy for you, and or questions to ask your healthcare team about changing dialysis therapies. You can also order materials by phone. We are excited to announce the 5th annual AAKP Fun Walk will take place virtually December 4th through 8th, with an in-person walk in Tampa, Florida on December 9th. Registration for the Fun Walk opens soon. You can also visit our YouTube channel to watch presentations on demand from our 2023 events and programs. Again, thank you, Dr. Charmaine Lok, Christine Hernandez, and Terry Perez for participating in today's AAKP Healthline webinar. And thank you to Medtronic for providing an educational donation for this program. Thank you all for joining us today.